next, we've got Sarah Fallon, who's Chief Operating Officer for Greater Manchester Clinical Research Network, NIHR Clinical Research Network. I used to be involved in that. So, Sarah, can I pass over to you? And you're going to be talking about capacity building through the CRN.
Yeah, absolutely. Thank you so much. And thank you very much to the other presenters as well. I think, you know, Alice highlighting that really important point that actually, you know, boards are taking now, you know, huge notice of the infrastructure that's needed around research. And one of the things I'm going to talk about is centrally allocated resource that comes through different channels. And one of those that comes through the NIHR is to the Clinical Research Network. So I'm just going to pop some slides up just so you can see. Can everybody see that okay? Just put in full mode. Excellent. Thanks, Sophie. So we, as a clinical research network locally across Greater Manchester for this financial year, had 21 million to spend on infrastructure. And one of the ways that we utilise the majority of that money is to go into care organisations to pay for dedicated time for staff to set up, to deliver studies, to support, you know, all the support services that are required, to make sure that exactly as Alice rightly said before, you know, we're not diverting critical care resources into delivering research. So that just to kind of give you at the very, very beginning that there is funding there for studies that require support to be delivered. So, you know, there is support there to pay for hands on deck to get this important work done. In terms of the Clinical Research Network portfolio nationally, you know, there's almost 5,000 studies recruiting, obviously not just in mental health, but across the range of the 30 disease areas that are supported. And obviously a number of those have been in COVID over the last 18 months, but actually a lot haven't. And Greater Manchester as a region and as a research community have done very well to re-establish after the pause and continuing to grow, as you've heard from the ARC, you know, those critical research themes that do make a difference to our local, national and global communities. Funding nationally, there's, as you'll see there, 317 million that goes into all regions. That 21 million is for Greater Manchester, but there's 15 networks. And the real critical, I suppose the critical point that's important for is we can't, that, you know, we have to build our infrastructure locally, but we have to make sure that nationally all regions are built up so that we can work together to make sure that we do the best for all communities and all populations. And one of the fantastic things you heard before about the ARC is the connectivity across the ARC, supporting each other on development, and the clinical research networks aren't any different. And just at the end, you'll see, you know, that's almost, you know, 7,000 whole-time equivalents in terms of people who that funding goes into support every year to make sure that research does happen and can happen, and we're not taking critical resource from other parts of the system. So how you know, why bother, and you know, why can't, you know, as Alice said before, everybody could just do this on their own, and unfortunately it is incredibly tough, and one of the things here is about capacity building. It's very difficult if you're in an organisation who hasn't got research embedded to start, and it's also very, very difficult to grow at the pace that you need to without some support in capacity and capability development. So one of the things, the other thing that funding does is around strategic development for organisations. So understanding where we potentially need to pump prime initiatives, that might be some capability in pharmacy for its, you know, further IMP development, That might be about more access across communities if actually we need to find more and deliver more studies through communities, to ultimately make sure that we're doing the right research for the right people in the right place and being able to flex that resource as much as possible to have maximum impact. One of the other things that's critical as well is for us is making sure that the UK remains a place that is attractive to UK life sciences. You know, I was on an IQVIA call this morning where they've just awarded GMMH the first mental health study that IQVIA have had, and it's the first area in the north, which is brilliant. So well done. But actually, I know Pennine Care have got some real ambitions and have been putting in lots of feasibilities. And the life sciences is a place where actually you can get a lot of support as well through both the network support infrastructure for life sciences, but we have a huge sort of site relationship model across life sciences, and they, you know, they give up their time to work very closely with you as you know, teams, but also as organisations, to understand how we can get to the place we want to get to, so that we're in a position to place studies and the right studies. So how what do we actually do? So I've talked about some of the infrastructure in terms of people that we support to make sure that we can identify and recruit participants. But actually, there are some other things that we do. And one of the things that we do is, some people may have heard about Research for the Future, or you might have heard about Help Beat campaigns. So we had like Help Beat COVID, Help Beat Diabetes. And they're quite useful because you can build links with charities. And that allows people to consent to be approached about research, but also get involved in key PPI work in that space. And there's other things like systems, some of you may have heard of Farsight or CPRD, and other tools that essentially allow you to search and find on top of health records. So when you are actually looking potentially for maybe a very niche, you know, participant population, or, you know, a specific community, or even a broad community, it'll pick those up as well. There are capabilities within the Clinical Research Network where we can put in certain inclusion exclusions, and then it will tell us what, I suppose, firstly, whether it can be done, because as many of you who may have done research before will know, there are a lot of elements to a protocol that mean all of a sudden nobody's eligible. So we can get the development right, and that's another important part. We can help develop that and help you get that right. But the other thing is then we can make sure that we can understand where you can find those participants, and we can link in with GPs who can then send letters out to ask people if they want to be part. But another key aspect is actually we can look at where people exist that might be suitable for inclusion exclusion, and also then look at heat maps that look at prevalence and deprivation. So we can understand, just because there's a lot of people, are they the people that need it the most? You know, are they the people that are maybe most deprived in an area, and are there key communities that we should be working especially, you know, hard to make sure that we connect with and we give those opportunities to. For some of you who may have done your own grants before, you'll know that cost attribution or SOCATs are, I'm sure, your favourite thing, and they are basically a model where you can work out how much it's going to cost and how all the different elements can, you know, of funding bodies, both in terms of the research costs, but the service support costs and any excess treatment costs, to make sure that you're getting the right income for your study, and ultimately your organisation is getting that income and you don't get left with a bill or not able to do your study. And our team are, you know, we support people with cost attribution or costing models, and we can help with the study setup, and we support organisations who maybe haven't set up certain studies before, and it's a new area for them. Our team will work with those teams in organisations to make sure that they, you know, feel confident in maybe doing something a bit different. The other thing, just to kind of plug as well, is we provide free training, education opportunities through NIHR Learn, and I'll can share these slides afterwards, and that's a link in there, hyperlink. That's got lots of online modules that you can work through at your own pace, but it's also got face-to-face opportunities. So depending on what type of learner you are and depending on what needs you are, you can put what type of research you're doing, and it will recommend courses for you in your role and your specialty or area of interest. And it will also then tell you about things that are happening locally that then you might want to know about, and it gives you hot topics. So it'll let you know when there's maybe something that you might need to know, but it might not be your time to refresh your training, but it might be of interest. So that's something that I think would be really useful, and it's absolutely free for people to access that. And then the other thing that we do, as well as doing the day job, doing the study delivery continually, is we also provide strategic programs that ultimately strengthen our regional capability to deliver research in a better, more connected way as a geography across different, care organisations and different systems that exist across health and social care. So this year we have spent about 700,000 on people who've come to us with an innovative idea, saying, if we could do this, we will then be able to do that for years to come. So that's, if people have ideas, we'll be putting our strategic funding out after Christmas for the next financial year, and they're really key pieces of work, because we want to deliver research, as quickly as possible so that we can make sure the best care is available for everybody. We want to work smartly and efficiently to do that, which sometimes means we have to pause and see if there's a better way of doing what we're doing. So for people who maybe have ideas, we're all ears. This is just a little plug for our delivery team. So we have our own delivery team, as well as putting infrastructure into all of the different organisations. One of the other things that we have is that there's about 20 staff now across our direct delivery team, and they predominantly work outside of hospitals. They're a mix of roles from nurses, practitioners and administrators, and they are fabulous. But actually one of the best things about them is they love the variety. They'll go and work in schools and prisons, care homes, high street chains, they'll work in community hubs. So, if there are studies where actually what you need is the money isn't going to help because you're struggling to attract somebody, one of the other things that you can access is you can fill out a form and explain that you need some support from our direct delivery team, and we do our very best to support that for as long as possible. And very lastly, this is just a little plug to say you can only get access to the Clinical Research Network support if you put your study on the Clinical Research Network portfolio. And I've put that there, that usually this needs to be done in setup. If you are in the middle of a study, there are sometimes ways that there is a criteria for retrospective adoption if support is going to be critical to the success of that study. But come and talk to us now, and that's the central mailbox where the study support service team will take those queries. So we can help you with any point if you connect with us, and we'll talk you through that process. And that's it. Was I all right, Shona? Was I okay? I see you've come back on. Were you my warning?
Yeah, that was great. Thank you very much, Sarah. And there are a few questions in the chat for you, which I guess with Bernadka we'll pick up at the end. Gave us a terrific overview. Thank you very much. That